We're going to review some of the bleeding disorders now. The history, as always, provides useful information to help you with your diagnosis. On physical exam, the type of bleeding is helpful. So if they talk about mucocutaneous bleeding, or if they talk about petechia or small ecchymosis, that's more likely going to be von Willebrand's disease or some kind of platelet dysfunction. If they mention bleeds into bigger, deeper tissues like into the muscle or into the actual joints, if they use the term hemarthrosis, then you should be thinking of specific clotting factors. Initial workup includes a platelet count because you worry about thrombocytopenia, and obviously the PT and PTT will be helpful for various clotting factors. If the platelets, the PT and PTT are normal, then you should proceed to do von Willebrand factor testing and do a thrombin time. If they are abnormal, then you have to check for specific clotting factors. The bleeding time actually measures platelet function and also interaction of the platelets with the vessel walls, and are useful it's useful to do the bleeding time for a qualitative platelet defect or also for von Willebrand's disease. The PTT, as you recall, measures the intrinsic pathway, so that's going to be factor 12 all the way to the final clot. The PT measures the extrinsic pathway. And also remember that now we use the INR, which is the standardized international normalized ratios. Thrombin time helps to measure the final step of fibrinogen to fibrin. Also, patients can have mixing studies done. What you do with a mixing study is you add normal plasma to the patient's plasma, and then you repeat the labs. If the prolongation or the abnormality is now corrected, that means that you have a deficiency in clotting factor because you're providing it with the normal plasma. You can do specific clotting factor assays, and for sure on the factor 8 and factor 9 deficiencies, that's the only way you're going to tell them apart is to test for that specific clotting factor. The platelet aggregation studies or the ristocetin test is for a qualitative test for platelet dysfunction. We're now going to discuss specific ones such as hemophilia A and B. Hemophilia A is the classic hemophilia. It's a factor 8 deficiency. Hemophilia B is the factor 9 deficiency. The majority of hemophilias are factor A deficiencies. 85% of them are going to be factor 8 deficiencies. It is an X-linked recessive trait, so it will be present only in males. The females will be the carriers, and you can trace this all the way back to Queen Victoria and blame her for this because she was the carrier, and then everybody else got it from her, and all the daughters that carried it and the males exhibit the disease. The clot formation is delayed with hemophilia A and also with B, and many times they will bleed into a closed space. So again, the hallmark of hemophilia A and B is going to be hemarthrosis, spontaneous bleeds into the joints. If they bleed into a closed space, it pretty much limits itself and tamponades itself. If they're bleeding into an open space, you can have severe blood loss. It sometimes goes undetected in the newborn period, but sometimes you will see this as prolonged bleeding after a circumcision or after injections. Look for a history of easy bruising when the patient starts to crawl or walk or starts bumping into the crib and things like that, and they'll start to have easy bruises and sometimes to have the bleeds. Again, the hallmark is hemarthrosis, and sometimes it can be life-threatening if there's a bleed in a vital structure. The joints will sometimes be deformed with these hemarthroses. The bleeds tend to resolve, but then can reoccur. The laboratory evaluation, the PTT will be elevated to 2 to 3 times normal. You can correct this bleeding abnormality with a mixing study. So you add normal patient plasma to it, and all of a sudden the PTT goes back to normal. It tells you that you have some clotting factor problem. And the specific assay for the factor is the definitive proof. So if you suspect factor 8 deficiency, you order factor 8 activity, and for factor 9 you order factor 9. Typically you order both, and then the one that comes back abnormal gives you the diagnosis. So remember that the best test is going to be a specific factor assay. Carriers, that would be the girls, will have a decreased factor 8 von Willebrand factor ratio. Patients with hemophilia will have a normal platelet count, they will have a normal PT and a normal bleeding time, as well as a normal von Willebrand factor. The treatment of hemophilia is to replace the specific factor. So if you have factor 8 deficiency, you get factor 8 concentrate. If you have factor 9 deficiency, you get factor 9 concentrate. Children will sometimes receive prophylactic factor 9. They're more prone to have bleeds because they're always moving around, and so that is to help prevent those hemarthroses. Obviously, you already have one bleeding problem. You want to avoid any other problems or exacerbating your own, so you want to avoid aspirin or any medications that have any antiplatelet function. Sometimes DDAVP is used to help increase factor 8 levels if they just have a mild disease. Otherwise, you're going to use concentrate. Von Willebrand's disease is the most common of the hereditary bleeding disorders. It is autosomal dominant, so again you will see it present in every generation, and since it's autosomal, it affects females as well as males. In fact, historically, it's a little bit more common in females. It's a problem with the function of von Willebrand factor. Von Willebrand factor promotes platelet adhesion and platelet aggregation, and is also a carrier protein for factor 8. So you can see how von Willebrand factor helps in clotting in a variety of ways. The presentation of von Willebrand factor is going to be mucocutaneous bleeding. Look for bleeding from the gums. Also, they have easy bruising. They can have nosebleeds. Now, we said in an earlier chapter that the most common cause of nosebleeds is going to be picking your nose, but sometimes a patient may have von Willebrand's. Look for a history of bleeding, easy bruising in the family, because this is an autosomal dominant disease. Labs will help you differentiate the types of von Willebrand disease. You will have an increased PTT and an increased bleeding time, but the best test is going to be a quantitative assay for the von Willebrand factor antigen. You can also get activity and do a ristocetin cofactor activity. Also get other factor levels because you want to rule out other diseases. The management of von Willebrand disease is to increase the levels of von Willebrand factor and also factor 8. Patients with type 1 von Willebrand disease will respond to DDAVP because it will induce a release of von Willebrand factor, so there's more of it circulating. But types 2 and 3 diseases will need actual replacement of von Willebrand factor. One way of doing this is giving fresh frozen plasma or cryoprecipitate. You probably won't need to know the different types of von Willebrand disease, but do know that the treatment will include DDAVP and cryoprecipitate or FFP. Other bleeding disorders. When we talked about the newborn, we said that one of the first things that you do to a newborn is give them vitamin K. So we give it to them intramuscularly, and this helps to prevent bleeding problems. Remember, vitamin K is instrumental for clotting factors 2, 7, 9, and 10. Postnatally, vitamin K deficiency can occur with lack of oral intake or malnutrition. Remember, we get vitamin K basically from gut flora. If we have malnutrition, malabsorption, you may not be getting adequate vitamin K. And always remember long-term antibiotic use. This is a common topic sometimes in medicine. Patients that have been on antibiotics for quite some time and have bleeding problems, remember to supplement with vitamin K. You can sometimes see this in the pediatric population. Vitamin K has to do obviously with the fat-soluble vitamins, and so there's your factors 2, 7, 9, and 10. Also has to do with vitamin C and S. Liver disease can cause bleeding problems. All clotting factors are produced in the liver. So any type of liver disease, with the exception of factor 8, any type of liver disease can affect clotting also. So think of liver disease in a patient that has easy bruising and bleeding. And the treatment will be to give them FFP because all clotting factors are in fresh frozen plasma. Also, cryoprecipitate is replacement therapy for patients with liver disease. In your lecture notes, there will be a nice table with all the coagulation labs, and I recommend that you spend some time reviewing those.